So I guess I have the pleasure of welcoming everyone to the second day of the summit. So good morning, everyone. Here to our session today where we're talking about health inequalities and really thinking about how they can be addressed through community mobilization and engagement. So before we get started, I think I'd like to do two things. I think if we're talking about health inequalities, it's very important that we do acknowledge that we're standing on the traditional and unceded territories of the Coast Salish people, including the Squamish, Musqueam, and Tsleil-Waututh people. And that's an important thing for us to keep in mind going forward in this keynote. I'd also like to start by really acknowledging the privilege that I feel of being in this space and the kudos to the CBRC and the organizers of the summit. I think every year the summit just keeps getting better and better, and I think it is really a privilege and an honor to be here in this space, learning from each other and hearing about the experiences of other people. So kudos to the CBRC for that. So my name is Mark Gilbert. I'm the Medical Director of Clinical Prevention Services at the BC Centre for Disease Control. And as I was reflecting a little bit myself on this session, I realized that as someone who is trained a physician in the medical system, a public health provider, I want to acknowledge that I, like many of my peers, are afflicted with a chronic disease which I call risk factor-itis, that we tend to focus on diseases and risks and vulnerabilities, and that's where we tend to focus and think that we have to prioritize our actions. So I remember when I was first learning about gay men's health, I heard about these terms when I was speaking actually to many of the people in the room about things like resilience and mobilization and assets-based approaches. And I remember at the time that it sort of sounded like it makes sense, but it wasn't actually until I actually really heard from people who were implementing programs and doing some of the great work in Vancouver around that I really fully got a better understanding of what that meant. So then I'm really excited to be here today as a moderator for this keynote because it's going to touch on many of those concepts. I'll start by introducing our three speakers today. So we're going to start with our keynote presentation by Lisa McDaid. So Lisa is someone who I've gotten to know over the past few years because of her work in gay men's health and health literacy. Lisa leads a program of research on social relationships and health improvement at the Public Health Sciences Unit at the University of Glasgow. She's particularly interested in the development and evaluation of complex interventions to improve public health and has expertise in sexual health and HIV. Lisa's current research is focused on the development of interventions to improve sexual health literacy, engaging gay communities in HIV prevention and health improvement research, and the development and evaluation of asset-based community participative approaches to reduce health inequalities. I've introduced you twice and I've stumbled over the same word both times. So we're going to start. So Lisa's going to give a keynote presentation for about 40 minutes, and then there'll be a chance to ask some questions of Lisa at that time. And then we're going to move into what we're sort of hoping is going to be a dialogue and exchange part of this session, and we'll be welcoming two additional people to this stage. We'll welcome Brooke Biggin. So Brooke is a proud queer and pause community organizer and recently named as one of Edmonton's top 40 under 40 by Avenue Magazine, which is fantastic. Woohoo! I think we were all excited to see that. Brooke holds contracts with HIV Edmonton and the Alberta Community Council for HIV and was just appointed to the steering committee for Alberta's new STBBI strategy. He's the founder of the Edmonton's Health Collective, a grassroots queer men's health organization whose vision is to see Edmonton queer men have equitable opportunity to experience positive health and well-being. So Brooke and Lisa will also be joined by Aidan Oblona. Aidan is a proud queer Filipino with a passion for social justice, health equity, community development, and youth empowerment. He's been involved with the field of gay men's health since 2013, with experience both as a research assistant at Ryerson University and as a volunteer at various community health organizations such as ACT, Hassle Free Clinic, and Supporting Our Youth. In early 2015, he helped to create Our Space, a Toronto-based grassroots collective of young guys who like guys, who seek to support, develop, and empower each other in our communities. He currently coordinates the Investigators in Toronto, a hands-on research training program for young guys interested in gay men's health and community-based research. So welcome, and thank you for Brooke and Aidan and Lisa for being here today. All right, so I've said enough, and I will turn it over to Lisa.
Thank you very much, Mark, and thank you for that lovely introduction. I also struggle with the word participative, so I've to community engagement instead. And I think that really encompasses what we're going to talk about today. I'd like to, first of all, thank the organisers of the summit for inviting me to talk to you today and tell you about the work that we've been undertaking in Scotland. It's a real privilege and an honour to be here. This is my first visit to the summit and I'm really enjoying the event. I've gained a lot of new knowledge and I'm really quite inspired by some of the work that's happening here in Vancouver and elsewhere within Canada. And I'm excited to share this session with Aidan and Brooke and hear more about the organisations that they're involved in, because I think we can really learn a lot from those. So thank you for that. So really, when I was invited to give this presentation, it got me to reflect on a lot of the work that I've been involved in over what's now the last 17 years. I started work at the Social and Public Health Sciences Unit in Glasgow as a junior research assistant. And one of the first jobs that I did and one of the first projects I worked on was an evaluation of the Gay Men's Task Force, which was a community-based peer-led intervention to try and increase HIV testing and reduce sexual risk behaviour amongst men. And in a nutshell, it didn't work. And when we reflected on why that might be the case, we were very acutely aware that we'd taken an intervention from an American setting, so it was based on the popular opinion leader model that had worked very well within that context, but to then try and translate it into a very different context, so the city of Glasgow faced real challenges. So then over the last 17 years, we've been involved in a lot of research thinking about HIV testing, how to increase rates of testing, and really work with gay men to think through the challenges, particularly around stigma in relation to accessing testing and managing risk behaviour. And now that I'm in a position where I lead a programme of research within the unit and I have a remit for community health, it's got me thinking again and reflecting on those past experiences around working with men and engaging in community mobilisation and trying to think about what we can learn from the past as we move forward. So really much of the research I've been involved in has included really diverse and varied gay communities. And in the time that I've worked in this area, there's been really major changes with respect to both disease and to health. And like Mark alluded to, often we focus on disease and risk rather than the positive aspects of health, and that's something that we'd really like to change in the work that I do in Glasgow at the moment. So we've seen a real change in the nature and the biomedicalisation of HIV prevention within this time, and also the blossoming of anti-discrimination and equal rights legislation toward the end of the 20th century and into the 21st. And at the same time, we've seen significant changes in the structure of gay communities and an increasing individualisation. And this has led some to question the ongoing relevance of gay communities today. But I think you just have to look around this room to see that really that's not the case. And in the UK at the moment, there's been a lot of debate about a resurgence of gay community and of HIV activism. And this relates to NHS England's decision not to fund PrEP. And it's been argued that this has reignited activism and reinvigorated a profound sense of community. So I think this really demonstrates that community is very much still a powerful idea. And I'm really pleased to see today that the Court of Appeal in England has upheld the ruling that actually NHS England should fund PrEP for people who need it in the UK. You might have missed that because it's been slightly buried in the news cycle with what's happened in America. So really what I've been doing over the last few months within my work is trying to think about how we can revisit this idea of community mobilisation and take forward a new approach to community health improvement with gay men in Scotland. And I put new in brackets because it really isn't new. And I think what struck me in the short time I've spent here in Vancouver is that there's lots of really positive examples of this working in practice. And that's why I'm really pleased to share this session with Aidan and Brooke, who are going to talk through their experiences of doing this in the real world as it is later on. So what I want to do today is just reflect a little bit on the Scottish context, as I'm aware that many of you might not really know where it is even, and some of the challenges that we face in relation to health. I'll talk about the progress we've made in terms of improving health and some of the challenges that we still have in terms of reducing inequalities in health for gay men. And I'll reflect a little bit again on this idea of the changing context and the norms and practices linked to this idea of how a community has changed over time. And then I'll finish with what we now see as a new way forward for us in community health, which I think will link very nicely into Brooke and Aidan's sections. So first of all, let me say a little bit about Scotland and where it actually is. So Scotland's one of the 4 nations that make up the United Kingdom, which is a very small island just off the coast of Europe, and we feel much more removed from Europe now after the Brexit result earlier this year as well. So it's just around 4,500 miles from Vancouver, so quite a distance to travel. And Canada apparently is 127 times bigger than Scotland, so yeah, we're rather small. And in fact, when you look at the whole of the UK, it fits within British Columbia. So I think that gives you a real sense of the scale of the country that I come from. So Scotland is shown in red in this map, and it's the northern part of the UK, of the British Isles. We have a population of around 5.4 million, and the largest city is Glasgow to the west of the country, which is around 500,000 people living within it and the surrounding area. And I live just outside that city myself. Our capital city is actually Edinburgh, which is on the east of the country, and there's actually just 40 miles between them, so it gives you a sense of the scale. We don't have far to travel between our major urban centres. However, we also have a really broad range of rural, remote and island communities which we seek to serve. And a recent online survey of gay men that we conducted found that around half lived in this Glasgow and Edinburgh area that's known as the central belt of the country, but the other half were really dispersed across the broad spectrum of areas and communities in across Scotland. So overall, Scotland has a very poor health record in comparison to other European countries, and there's considerable inequalities between different social groups and regions. And just recently, this week, in fact, there was a news report that's highlighted that 1 in 3 children in Glasgow grow up in poverty. So there's real disparities in terms of access to amenities as well. So as I'd mentioned, Scotland is one of the 4 nations that make up the UK. And we might have voted against independence a couple of years ago now, but a lot of the governance of Scotland is devolved to the Scottish Parliament, a picture of which is included here. And healthcare is one of the aspects which is devolved to the Scottish Government. So within this, sexual health services are made available free of charge via the publicly funded National Health Service. And health is provided across Scotland via 14 regional health boards. And these work in partnership with the local authorities to provide integrated health and social care. And this includes a remit for community sexual health services and health improvement. Scotland also has its own sexual health and bloodborne violence framework, the first of which was published in around 2010 and recently updated. And this is a really broad framework. It's outcomes-based, but goes beyond the usual desire to reduce infections around STIs and bloodborne viruses, but also takes a very holistic view of sexual health. So I want to now move on and talk a little bit about gay men's health and wellbeing in Scotland and highlight some of the key aspects in terms of improvements that there have been in health over the last few years, but then also the challenges that we still face. So gay, bisexual and other men who have sex with men account for quite a small proportion of the male population in the United Kingdom, but they are most affected by HIV. And they also currently account for the majority of syphilis and gonorrhea diagnoses, which suggests that sexual health is a key issue for us to address. So since I've worked in the unit, we've conducted the Gay Men's Sexual Health Survey. And over the time that we've run that survey, it first started in 1996 and has been repeated every 3 years since then. We've surveyed just over 12,500 men. So the survey is a cross-sectional design that's conducted in the gay bars, clubs and saunas, primarily within Glasgow and Edinburgh, the 2 major urban centres. And we use a form of time and location sampling in order to access a range of men accessing the bars and other areas of the gay scene across a short period of time. And that's allowed us to be able to look at changes in sexual behaviour and HIV prevention and testing of gay and bisexual men in Scotland over time. And I think the key thing I want to highlight is how we have seen major changes in terms of HIV testing over that time period. So in 1996, when we first started to collect these data, HIV testing rates were very low amongst men in the community-based samples. Just half of men had ever had an HIV test, and 28% reported having had a recent test within the previous 12 months. And then we've seen really quite substantial and significant changes in this over time. Just around 2001, 2002, the Scottish Government had issued their first strategy towards sexual health, a key tenet of which was a change to opt-out HIV testing. And this has been one of the key drivers in really increasing testing rates amongst the community sample at the community level across time since then. So when we last conducted the survey in 2014, almost all of the men surveyed had had an HIV test at some point in their life. And now 60% reported having had a recent test in the previous 12 months. And in addition to the move towards opt-out testing, we've reflected on how health improvement interventions within Scotland have had a real focus on trying to drive up HIV testing rates. The need for frequent regular testing was a particular focus of Scottish HIV prevention efforts, such as the Make Your Position Clear campaign, which was funded by an alliance of health boards across the west of Scotland, and these are some of the images from that campaign. And it sought to promote both the use of condoms and lube, but also a regular STI screen, which would include an HIV test every 6 months. And these campaigns have been credited with increasing testing rates and the awareness of HIV risks. However, we've went on to look at the actual frequency of HIV testing amongst gay men in the UK. And current UK guidelines suggest that all gay men should have at least an annual HIV test. And those who are at higher risk should test up to every 3 months. The definition of high risk is often quite vague and non-specific, which obviously makes it challenging. But from the community surveys that we conducted in Glasgow and Edinburgh, and also combining with those of our colleagues in London and an online survey, we were able to look at the proportions of men who were reporting both annual and more frequent testing. So we found that just over half of the men we'd surveyed reported annual HIV testing. But fewer than 1 in 5 reported what we had called frequent testing. So these were men having 4 or more tests in the past 2 years, which would suggest possibly 6 monthly testing. So that suggests that the men who take part in our community surveys were not yet meeting the current UK guidelines on testing. And this is important and is something that the Scottish Government are interested in because they have made a commitment to meet the UN AIDS 90-90-90 targets. And we heard about those earlier this morning as well. So in terms of access to treatment and viral suppression, Scotland is doing very well and is meeting that 90% target. But in terms of the diagnosed population, we're still falling short. So the current estimate is that 17% of people with HIV in Scotland are undiagnosed. In our last community survey, when we looked at undiagnosed infection amongst the gay men who took part in that, the level of undiagnosed infection was actually much higher, at almost 40%. So clearly there are still challenges for us to address. And as I mentioned earlier, the Court of Appeal in England has just made the decision that PrEP should be funded by the NHS in England. And I think that debate will rumble on for some time yet before PrEP's actually made available. But in Scotland, the Scottish Government has made a commitment to considering the provision of PrEP for men who need it and for all populations who need it. And we're currently waiting the recommendations of an advisory group as to how that will be taken forward. And I'm very sure and hopeful that there will actually be a decision to make PrEP available to men in Scotland. So I want to reflect back on the sexual health and bloodborne violence framework that I mentioned earlier. And I think one of the key strengths of that framework is that it does go beyond just trying to reduce infection and count the number of people who are tested. It talks about wanting to reduce health inequalities and enable people who are affected by bloodborne viruses to lead longer and healthier lives. And it also talks about the need to try and target and counter coercion and harm within relationships. And I think most importantly, to encourage a society that's positive, non-stigmatising and supportive. And I think really now, in order to be able to deliver on that, we need to go beyond HIV and go beyond sexual health to fully impact on health inequalities. And this is what we're now starting to think about, and it reflects on what Mark had mentioned earlier in terms of assets and looking beyond sexual health. So some findings were published earlier this year from some colleagues in England as part of the NATSAL study. So NATSAL is the National Survey of Sexual Attitudes and Lifestyles in the UK, which is conducted every 10 years. So it is a very small sample of gay men, but within this, they looked at the proportion who were experiencing multiple health inequalities. So they looked at the numbers of men reporting poor mental health, poor sexual health, and then also substance use, and the overlap between these. So it's quite a complicated slide with a lot going on, but I think the key thing to highlight is that within the very small sample of gay MSM, so these are men who identified as gay, almost half reported at least 2 of these health inequalities, and 1 in 10 reported all 3. So that is they're experiencing issues with mental health, sexual health, and substance use. So I think now at this stage, we need to try and understand more about how these inequalities amongst gay men are interrelated and what we can do about it. So following on from this, the report was published by Public Health England not that long ago that sought to promote the health and well-being of gay, bisexual, and other men who have sex with men. And within it, they presented this figure on the determinants of health inequalities trio. And it talks about this overlap between sexual health, mental health, and then also substance use. However, the report's only able to set out interventions that address sexual health, mental health, or substance use separately. And I think there's some key knowledge gaps for us still to address. So few studies have looked at how psychosocial problems, substance use, sexual and mental ill health are related to each other. And none of the available research evidence considers the delivery of multiple tried and tested interventions in tandem. So it's very apparent to us that the inequalities that are experienced by gay men are complex, and therefore their health improvement will require complex interventions that does try to target these interrelated health inequalities. But also, in reading this report, I was quite struck by the fact that actually isn't there something missing from it? And what about the influence of the communities around us and the societies in which we live? So if we look again at that figure on the health inequalities, it does point to the role of services, to our communities and policy in influencing these inequalities. But what about the broader context in which we live as well? And I think it's absent from that figure as it stands at the moment. So a lot has been said in the UK in terms of societal changes and positive changes in relation to discrimination and equal rights, and I alluded earlier to the changes in legislation which have included equal marriage within the UK. And these have been linked to changes in public attitudes to same-sex relationships. And the Scottish Social Attitudes Survey, last published in 2015, talked specifically about attitudes to same-sex relationships and equal marriage. So this figure shows the proportion of people who are unhappy or very unhappy with a close relative marrying or forming a long-term relationship with different groups. And don't get me started on the negative language and the fact that they focused on the negative rather than the positive. But what it did highlight was that the proportion who were unhappy or very unhappy with a close relative marrying or going into a relationship with someone of the same sex had dropped from almost a third in 2006 down to 16% in 2015. And in Scotland, this is taken as evidence of changing societal attitudes to gay and bisexual and other men who have sex with men. However, at the same time, I think we still have a real issue with stigma and discrimination. So the Equality Network in Scotland conducted an online survey of just over 1,000 lesbian, gay, bisexual and transgender people in Scotland. And in that, they report that 79% experienced some form of discrimination in the last year. And this included homophobic comments and attitudes, acts of verbal, physical and sexual abuse, and discriminatory treatment when accessing both services and in employment. So clearly we still have quite a long way to go. So I want to come back to this figure about the health inequalities and how they're interrelated and reflect on whether there is something absent from it. And in fact, maybe we need to think about how this sits within the negative social environment that's driven by stigma and discrimination. And in order to try and counter this, we need to think about a new positive community response. So reflecting on that need for a new community response, I want to talk a little bit more about the changing context and norms and practices that I alluded to at the start of the presentation. So as I'm sure that most people in this room are very aware, community responses to HIV have long been linked to successful HIV prevention amongst gay and bisexual men. And the creation of safer sex amongst and by gay men in the 1980s as a response to HIV really represents the best recorded evidence of population-level behaviour change. And I think there's extensive evidence of the success of peer and community engagement in facilitating sexual health and HIV prevention. But we now hear much more debate and comment on the fact that the structure of gay communities has changed. There are different patterns of socialisations and new ways of connecting socially and sexually. And it's led myself and my group within the unit to think about, well, what are the implications of these changes? Much has been written in recent years about gay men's ambivalence to their communities or the loss of community, and whether communities were dying or transitioning to a different form. So we were interested to try and understand what men in our communities in Scotland thought about these issues and who they saw their communities as being, and how engaged they were with the concept of gay communities as presented in this academic research literature. So my colleague Nicola, who at the time was conducting her PhD with me, did a study looking at trying to map out and analyse young gay men's personal communities. So this was the idea of trying to understand who the support networks were around them and who they turned to, particularly in relation to safer sex and knowledge around issues to do with HIV prevention and testing. And she got young men to map out on these diagrams who were important to them, who they turned to, who they talked to, who they didn't, and where they situated members of their communities in relation to them. So the closer someone was to the middle of the diagram, then the closer they were seen to be in terms of their support network, and someone they would be more likely to talk to than who was out with the diagram. There are limitations to this approach because it is essentially a snapshot in time. And some of the men themselves did comment on the fact that, they'd maybe recently had an argument with a friend and they would have been at the centre of the diagram a week ago, but now at the time of the interview, they were very peripheral to the men's communities. So I think that's a challenge for using this type of methodology. But what was good was that it did get men that we interviewed to think about their broad communities and where they turned to for support in relation to a number of issues. So the results of that study were that we found that the personal communities of the young gay men who took part in it were complex and diverse. And they included a really broad range of people, from their partners and friends through their family, and then also professional groups and colleagues that they turned to. And many of the young men had very highly mixed groups of friends, both in terms of sexual orientation, but also in terms of gender. And the men articulated a very complex understanding of gay communities, but they didn't necessarily frame these as being a central organising factor in terms of their personal communities. But what was clear was that men's understanding of safer sex was shaped by social norms, particularly within their personal communities, and a reflection on the wider gay communities in which they did live. So this slide is obviously very detailed, and I don't expect you to be able to read it all. But I think what it demonstrates is that there's a real diversity of experience in terms of the connection to community. So it highlights all of the ways in which gay community was conceptualised by the young gay men that we interviewed. And I think we need to try and take this into account when we're thinking about how we develop interventions that build on community engagement models. There's also much debate about the digitisation of gay communities, and these often focus upon the idea that there's a radical and polarised difference between the old physical world and the newly developing digital worlds. But really, I think all that this represents is that there's new opportunities and means for us to connect socially and sexually, and these are evolving rapidly and almost continually sometimes in a way that's quite hard for us as researchers to keep up with. So what we need to do when we're thinking about digitalised health promotion and how we engage with communities within the digital world is how our traditional interventions might translate within these. So many of our interventions rely on the social determinants and social influences of health to change communities and culture, and actually they should be relatively easy to translate. But we do need to think about how we adapt our research methods to the digital world. And we also need to think about who might get left behind. So could material resources and issues such as digital literacy amplify existing health inequalities? And I think we're already seeing some of this in terms of the community response to access PrEP in the UK. So there's been a very organised community response to promote access and really fight against the NHS decision not to fund it. And this is played out within the digital world and often with the rejection of any dissenting voices. And when we examine the awareness and willingness to use PrEP amongst men, using a mixed method study in Scotland. So here we're drawing on an online survey of gay men that was conducted by my colleagues Paul Flowers and Jamie Frankis at Glasgow Caledonian University, alongside some qualitative research that myself and my colleague Ingrid Young had conducted. So we found that men were aware of PrEP and they were willing to use it. But when we looked at the qualitative data, it was really very much complicated by patterns of sexual practice and social relationships. So it wasn't a straightforward yes or no as to whether PrEP would be used. And we also saw a really strong patterning of inequalities in terms of both awareness and willingness to access PrEP. So when we're thinking about biomedical HIV prevention and where that sits within the HIV prevention toolkit, we need to think about how we can ensure equity of awareness and access across quite diverse communities of men who have sex with men. And for us in Scotland, this means trying to think through the issues that we face around geography, different education levels, different scene use, and also proximity to HIV and differing levels of sexual health literacy. And I was quite struck by Daniel's talk earlier in terms of stigma in PrEP, and it really resonated with a lot of the data that we had from men in Scotland, albeit from a hypothetical context of using PrEP. So the final section of the presentation, and before we move on to talk to Aidan and Brooke about their own experiences, I just wanted to reflect on our thinking and where we've now got to in terms of trying to address the challenges around health inequalities for gay men in Scotland and what this new approach to community health improvement might be. So I'll come back to the diagram that I presented earlier, where we have these interrelated syndemic health inequalities, this overlap between sexual health, mental health and substance use, situated within this negative social environment that's driven by both stigma and discrimination. And really, in order to think about how we can develop a new positive community response to those, is that we need to try and understand more about these syndemic health inequalities, how they're related to each other, and what we might do about them. So I think this draws very nicely on the syndemics theory literature, and I've heard others refer to this already at the summit. And syndemics theory suggests the core occurrence of multiple interrelated disease epidemics at the individual and population level that are sustained by harmful social context. And I think this is the challenge that we face in Scotland at the moment in terms of moving forward with gay men's health. And the same group in the US also talk quite eloquently about resilience. In some of their published papers, they've reflected on the fact that HIV prevention work would be more efficacious if it was designed to incorporate naturally occurring resiliencies that manifest amongst gay male communities rather than primarily using interventions that address vulnerabilities among men who continue to reside in high-risk contexts. And I think I've spent a lot of time in recent months reflecting on the theory around these issues around resilience and around assets, and it's been really refreshing to come here to Vancouver and actually see a lot of this happening in practice. So in Scotland, we're now thinking about what this alternative approach could be and whether we can develop an assets-based model of public health to take forward to reduce health inequalities for gay men. So assets are the collective resources that are available to individuals for the promotion of health and well-being. And interventions that are based on this assets model focus on trying to enable the positive, the protective factors and resources of individuals and their communities rather than always focusing on the deficits and needs. And I think this is a really nice approach and a good way to think about things, and primarily because it puts people at the centre. It sees them as having the answer within their own communities to their own situations that affect them, rather than looking from the outside in. And I think this chimes nicely with the community's focus that I've already reflected on, because an assets approach will focus first on the individual to build resilience and coping and well-being amongst the most vulnerable within the population. But it also focuses on the links between people within these communities, on how we might access and use social support networks in order to encourage it, in order to further build resilience and coping across the community. And then it takes a whole community approach in terms of seeking to build on the strengths and resiliencies of that community in which we live. And I think this is really strong parallels with the success of community responses in the early HIV epidemic, which is why we're looking to it again now. However, when we looked at the literature and particularly engaged with the group in Glasgow who've done a lot of work around assets-based interventions in terms of physical communities and reducing the impact of deprivation, there's really very little evidence of effectiveness out there. And all of the work is very much centred on this idea of physical communities and trying to engage with those, which is obviously quite different from the work that we are trying to do and think about communities of identity and how we might engage there. And really, this approach is largely absent from UK health improvement efforts with gay men so far. So it's been really refreshing to come to Canada and find that actually others are talking about this too. And Mark introduced me to the HIV Stigma and Society report that talks about a way forward for gay men within British Columbia. And I was really struck to see that it refers to and makes recommendations for the use of these assets-based approaches that focus on framing interventions as staying healthy, over always focusing on the deficits, on the risks, and reducing risky behaviours. And I think really the work that Aidan and Brooke have been doing at our space in Toronto and at the Edmonton Men Health Collectives are really good examples of assets in action and their attempts from a grassroots organisation to create positive change. And in the second part of this plenary this morning, then we're going to now have a bit of a Q&A quick session with them about their experiences, which will be as much a learning process for me, I think, as for the audience here. Before we move on to that, I would just like to acknowledge the many people who have been involved in the work that I've presented on today. It's very much a collective community effort within my research group in Scotland and beyond. Thank you.